Thank you all for being here for our New York City Health and Hospitals Medical and Professional Affairs and Information Technology Committee meeting. Officially, the meeting is now called to order. And first order of business, if I can get a motion to approve our minutes from our last meeting.
So moved.
Let me just get our votes individually. Sally
Yes.
and Mitchell, Katz, thank you. And I am as well, so that passes, and we can now move on to our reports. So Dr. Allen, if you'd like to kick things off.
Yes, good morning. As you know, with the MMPA reports, we've been actually having different divisions report in on their accomplishments. And today I've asked Dr. Techie to share the work that she's doing with cancer care. Dr. Techie is a head and neck radiation oncologist, and she's currently serving in the system-wide position of Chief of Cancer Services. So, Dr. Techie.
Thank you. Thanks for the introduction. Should I advance my slides or, okay. All right, great. So we'll focus today on oncology initiatives and we'll keep it to 10 minutes, make sure I'm on time. All right, so these are the pillars that we are striving towards with our oncology work: quality and outcomes, care experience, financial sustainability, and access to care. And to set the stage, why are we committed to cancer patients, to cancer services? Well, our patients want to be treated in our communities, and cancer care really should be integrated with the patient's usual medical care, their primary care. Cancer screening is part of primary care, so it makes sense if you're screened to get the follow-up care within the same center. And we are capable of treating the vast majority of cancers. We do a very good job with the vast majority of cancers, so we should keep our patients in our system. And most importantly, we are committed to health equity and access for our patients. So I added this chart, which I thought would be a nice way to kind of summarize where our cancer services are. We won't go through it in detail now, but the point is that we have the majority of our sites do have access to cancer care, and even if they don't have something like a radiation oncology linear accelerator on site, we do refer internally as needed. And many of our sites are accredited, which is a really important thing because it shows that our patients are receiving a high quality standard of care, and we're aiming to further that accreditation in the future. So state-of-the-art care, it's really wonderful that our system has been able to acquire new technology for our cancer patients. We have replacement of several end-of-life machines happening at Elmhurst, which is actually going live in 2 weeks. So that's going to be the first site that can do single fraction brain radiosurgery, spine radiosurgery, which is a really important thing for our patients because right now we have to send those patients out. Queens will be acquiring a new linear accelerator next year, and Kings County is right behind them. In addition to having new technology, we're actually supporting the practices. So the practices need to be able to see the number of patients that require oncology care. So we have a business plan that's been built and deployed to support Kings County, Lincoln, and Bellevue with a team-based staffing model to make sure that cancer patients have a team taking care of them and are really getting the full standard of care. Here is a picture of the team-based staffing model. So this is really making sure that a physician, an advanced practice provider, and a PCI are working together so that the physician can really focus on the highest impact physician requiring work for a cancer doctor, which is making the diagnosis, making the staging, determining the right therapy. And cancer treatment has only become more and more complex, more and more costly. There's more drugs coming out every week, it seems like, being approved by the FDA. So we really want our physicians to focus on that piece of the puzzle and have a whole team taking care of them with advanced practice providers, PCAs, and all the other staff you see listed here. And to highlight some of what we've been able to achieve in the last couple of years, so we started a monthly cancer education series. This is really important for our doctors. Not all of our doctors are affiliated with an academic site that has a strong cancer program, so we're giving monthly grand rounds, inviting lecturers from around the country to speak on cancer topics, which our doctors have really loved, and there's CME available for that. We've been training our staff to make sure they know how to use the new technologies and the new machines. We've created a cancer care team for the practice at Kings County and are expanding that to other rad-onc practices. And our departments are now paperless, which means anyone from any site can access a patient's record. That wasn't actually physically possible in rad-onc before, so we're doing that now. And then to kind of tie it all together, what are the principles? How do I think about the care? I really want us to be collaborative amongst our sites. We don't all have to have the same technology at each hospital, but we need to be able to share that and make sure our patients have access to it. We want to be able to provide the care safely. We want to continuously improve, and that the patient care really has to be excellent. Our patients have to feel taken care of as a whole person when they're going through their cancer journey. And we are committed to providing timely, evidence-based, standard of care cancer treatments to our patients with Dr. Allen's support. Thank you, Dr. Allen. So we continue to do that. And that's it. Thank you for your attention.
Thank you. Superb report. Sally, question?
Just, I'm trying to understand your chart. I don't know what page it is. It's a chart that has the number of new cancer patients and then the services that are provided by facility. And on the radiation oncology, I noticed that Woodhull, South Brooklyn, and Bellevue, which interestingly has the highest number of new cancer patients being treated, doesn't have radiation oncology services. Bellevue refers out to NYU. So how did it come to be where the services would be located, do you know?
I think I know. I mean, I started here 2 years ago, but from what I've been told, it was whatever was advocated for and built in the local site. These machines have been there since about the year 1990 in some cases. So these plans were put well into motion in the 80s. And then they've just kind of persisted that that's where the machines were, and they've been updated. You raise a really good point about Bellevue. Bellevue does have the highest number of cancer patients. It's only growing. So we are starting to explore what it would look like to have that service at Bellevue on site instead of referring out.
So you'd have both the capital costs and the staffing costs, right? Yeah.
Would you educate us what is the cost of a linear accelerator, so people understand how high the mountain is?
Yes. The full package is about $4 to $5 million. The linear accelerator itself is about $3 million, and then the IT and the EMRs required to run it are another about $1 million. Then there's the CT simulator machine, which is a special type of CT scanner that's required for setting up the patient, and that's another about $1 million. So those are just the hard costs.
Right.
And then there's the operational costs, there's finding the space. So it's definitely a mountain. But we're still looking into it. And I think it can be done.
You know, you're always trying in the back of our minds to be as cost effective as possible and not duplicate. So, you know, if you have a linear accelerator literally on site, but at a different institution, you know, the question then becomes, there's some way of jointly looking at these, or NYU may have no interest in, but, you know, or at least collaborating, because, again, to duplicate the cost of, you know, something that's literally there, unless their capacity is being, you know, already maxed out, that's a different story. But I guess it's something to consider anyway in the future, I suppose, is there a way of doing that?
So before Dr. Techie arrived, each one of our hospitals was kind of doing their own thing. And Sweet has done a fabulous job in the past 2 years, thinking as an enterprise as well as thinking regionally. And her plan for the linear accelerators is regional as well. And she's just established a surgical oncology council and a breast cancer council. And surgical oncology is going to have to be regionalized the same way, but we're just starting that conversation because everybody wants their cases, but we have to start thinking about we and us. And the other thing I just wanted to share with you, which I might have shared before, really proud of what Dr. Techie has been doing over the past 2 years. She's really transforming how we're delivering services to our patients. I actually just learned this a couple of weeks ago. She's on the editorial board of one of the oncology journals, and she will be giving the plenary lecture to the National Medical Association in August. And I would like for her to practice that with our CMOs and our cabinets before she comes in.
I have a funny feeling she doesn't need a lot of practice. However, congrats. I mean, that's just magnificent. And, you know, it's a huge hill to climb, but for better or worse, unfortunately, oncology continues to be, especially as our population is aging, this is, become the diagnosis we're seeing and treating. And it is so multidisciplinary. And again, we do want to try to conserve resources. So you have a huge job ahead. It sounds like you're right on target to approach it, and I certainly congratulate that. I guess one issue, again, is research becomes such a critically important part, research protocols and so on, and maybe just sort of how we do fit that in as well, because, you know, for us, it sounds, we really want to make sure that we deliver the absolute cutting edge best services to the majority of patients and making sure everyone has got access to that type of care. But on the other hand, there are, again, protocols that are not necessarily yet adopted and so on, and that is an important part of oncology. And again, whether or not we have to be very involved in that or not, I'm just curious, though, is it an area we're kind of looking at?
Research is really important in oncology, and I completely agree with you. And I didn't really have enough room to get into it, but I'm happy to answer the question. So we have a lot of research partnerships right now. We don't have a lot of cancer research we are de novo doing, but we partner with other institutions. So we have a really strong partnership with Memorial Sloan Kettering, and I meet with them quarterly to kind of hear what we're doing and how we can continue to expand that. We want to expand into therapeutic cancer trials, not just diagnostic or supportive care, which had been what we've tended to do. Therapeutic trials require a different kind of infrastructure, a pharmacy infrastructure to be able to prepare the chemotherapy on site. So we've actually just submitted a grant to see if we can get funding to establish that. We would need like a chemo pharmacy in the regions and then be able to disseminate as needed the research drug. We are approached by multiple partners because of our population. So the opportunity is great, and we just kind of have to figure out how to use our resources to take the best advantage of it for our patients to have access to the care. I will say that on a micro level, our doctors do refer as needed to clinical trials all the time. We always talk about that in tumor boards. We make sure that our patients have access to that, but it would be great to have a structure that's a little more systematic through our system.
I appreciate that. And as you said, we have a huge number of patients that potentially are available for these studies, particularly populations that tend not to be studied as much. And, and again, recreating some of these things makes no sense, but collaborating, which is what you're doing at this stage, that, to my mind, is hugely important. And again, we just want to make sure that our patients and that information has come back and is disseminated for our people, so we kind of, know exactly and learn from, some of the protocols as they take place. Thank you. Other questions? Fabulous, great report and great work. Thank you for that.
Thank you.
Congrats on that
Thank you.
presentation you'll be giving. Thank you. All right, let us move on then to the next, which is our CNO report.
Good morning. Albert Bolaro, sitting in for Dr. Natalia Senius for the System Chief Nurse Executive Report. Thank you. We'd like to share the recognition event at Harlem Hospital for our Black Angels. They are pioneering Black nurses who treated tuberculosis patients at Seaview in the 1920s to the 1960s. Miss Virginia Allen was honored with a Lifetime Achievement Award. In Harlem, Harlem was also recognized by the Daisy Foundation in its role in providing nurses in treating tuberculosis patients. There was a book distribution for the event, and it was hosted by the Office of Patient-Centered Care with about 50 to 100 people attending. Next slide. We held a Certified Nurses Day celebration. This was March. The guest speaker was a national speaker from the American Nurses Association, Dr. Katie Boston Leary, and it involved Dr. Natalia Senius as well. to talk about the benefits and the value of certification in our journey to magnet recognition. Next slide. Fireside chats are continuing, and the last focus was on Nurse Builders. This is a free software given to staff, available to staff within Shine, and it gives free reviews, online certification reviews for staff that are interested, and that includes frontline and leadership staff. And this is in support of our quest for increasing nurse certifications across the system. Seaview, oh, Kohler. Kohler is has done something unique by getting the Silver Beacon Award for Excellence from the American Association of Critical Care Nurses. This is a long-term care facility getting that kind of an award from a Critical Care Nurses Association. And this was honored and recognized at the National Teaching Institute, recently held in May, where we also celebrated a dozen other Beacon Awards for a dozen hospitals. And just FYI, the Beacon Awards are quality designations for facilities in terms of structures and outcomes in delivering excellent patient care. These are the dozen awards that were celebrated at that conference. Clinical Ladder, we are, the growth of the Clinical Ladder program is growing exponentially. We have 2622 individuals, 2,622 have been approved in the 2024 program. And what's new in this year is that we have a platform that streamlines the approval and application of Clinical Ladder, and that has supported the increasing numbers going to the end of the year, when the Clinical Ladder incentives will be distributed. Nurse Builders, I think I mentioned this before. This is the platform that supports certification reviews for all nurses, and as you can see, the numbers to reflect engagement have already been quite a lot during the beginning implementation of this program. The Certified Nurses Day was held in March, and that was mentioned earlier. Professional shared governance, so far from 2020, we've completed 9 system-wide reports, 5 annual retreats, and 18 hospital-wide report outs so far. Our nurse residency program has reached a milestone of 2,000 enrollments. Citywide, there's a residency program hosted by the mayor's office. Our program is about 30% of that program citywide. We've graduated 31 cohorts so far, and we have 8 active cohorts at any given time, and we launch a new cohort every 3 months, 4 times a year. Our in mentorship, we are relaunching the mentorship program, and the same as the nurse residency program, this is aimed at keeping talent in the system by keeping our nurses staying more than the 12-month retention point. This is also embedded in the Clinical Ladder program. ED nursing fellowships have begun, and the intensive care unit fellowships have also begun. This is an outgrowth of the nurse residency program that has been widely successful. The nurse fellowship program and the critical care fellowship program, how it's different to the nurse residency program is that these are specialized transition to practice programs that support nurses after orientation. We all know from the literature that orientation is not enough. So orientation is supplemented by residencies and fellowships that engage our nurses to stay on for more than the 12 months and beyond in the system. I think the last slide, that's the last slide. Thanks so much.
Thank you for a great report. Questions or comments? Great work. And again, it's very clear couple of major tracks here. The quality and the awards that are coming in are magnificent, but if you don't have the nurses and if we don't keep them, that becomes a real issue. And I think these other programs that, between the residencies, the fellowships, it's great work. Hopefully, we're going to see the outcome, especially after our contract was settled and so on, that we'll hopefully see the outcome of being able to, retain our nurses. And I think that's going to be critically important. Hopefully, we're already seeing some of that in morale and so on. That
Yes,
I think
for the
these-
residency program, the retention for 2024 is 100% so far. Program-wise, it's 84%, and that's double the previous retention rate that we have in the past.
That's great work. That's super. Any other questions, comments?
Your
Sally?
new cloud-based professional development program for the nursing clinical ladder program saw a 25% increase in applicants, and that was just because of the new software.
Correct. When the clinical ladder program was launched, the application process and the submission process for documents was very difficult. And so the streamlining of that process has resulted in a 25% bump in the applications.
Impressive, thank you.
One issue, I believe, Sally, you asked me, the retention of whether or not the pay increases have raised retention for existing nurses. So I checked, we calculated it at the end of June because the historical has been the fiscal year.
Okay.
So we should know in July sort of what the overall retention rate was in this year and how it compared to previous years. And certainly our hope is, and we believe, based on more anecdote, that we have less loss of nurses than we've had historically. Also, Albert, I think we're up to 1,300 new nurses hired. Does that sound? I know we passed 1,100, and I feel like
Yes,
Talia told me we were nearing 1,300.
correct. That's a close estimate. I keep track of new hire, new graduates, and so far from November, we've had 1,200.
Yeah. So, and we think that we only need to be fully our own nurses 1,600. So, we're amazingly close to what seemed at one time an impossible goal, that we would use registry only for what registry was intended. That's what we want. We want to use registry for family leave and disability and when we're holding somebody's job, but no more, 4 years of registry. We're trying to completely eliminate that, and nursing has been incredibly successful at that.
Super. All right, let's move on then to the CIO report. Dr. Mendez?
Sure. While we're pull that up, I'll just want to, and for the minutes, I'll just introduce who's with me today. I have Dr. Michael Boughton, Apoorva Karia, Shoma Badori, Jeff Lutz, and myself, Kim Mendez. I'll just do a really quick, very high level, and then we're actually going to focus in on our health information technology prioritization of getting ourselves on this new EPIC honor roll and what that means for New York City Health and Hospital. But you can see within the report, we've actually had some significant upgrades to both our business as well as our clinical applications. And some examples of that would be in PeopleSoft, the human resource part of PeopleSoft, as well as the financial part of PeopleSoft. In addition, in the clinical area, we most recently in May had an EPIC upgrade, which I just really want to highlight. We were only down for 45 minutes during that, and that's the shortest amount of time that we've been down for an upgrade. So that was really a hallmark, and actually a new benchmark we're trying to set for ourselves, is to be more efficient in that area. We also launched Nuvolo, which is a biomedical device software for tracking each of the multiple thousands of biomedical devices that we have across the system. This not only helps us with maintenance and et cetera with our biomedical vendor, who is Crothel, but also with Shoma Badori, who's our CISO's department. It helps us with identifying any of the medical devices that may have a legacy or an older operating system, so that we can address it from a security perspective. And then in addition, we just launched Hello World. which Mike can talk about as well. I did want to highlight that we are launching the inaugural EITS Employee Recognition Award, very similar to, Nurses of Excellence. So we're very excited about that. And we'll have our celebration in September, which is National IT Professional Month. As well as we have within our current budget, we feel that there's a great opportunity to actually explore more grants within information technology. We have one that we've submitted, very significant one, with New York State, and another one that we submitted most recently with FEMA. That one was for security, so we're waiting for feedback on those. But as we ventured into those and getting our feet more wet in this area, we really feel there's a great opportunity, and we will build out that office. And then the last piece, which I'll bring back here for more information, is we are launching Going Green in IT, which is meaning a focus on print reduction. And then, Dr. Boughton, I'm going to turn over to you for our focused presentation.
Thank you so much, Dr. Mendez. So just while I get this pulled up, what I will expound upon a little bit is what we did with our downtime. So these are our planned downtimes. We do 4 of them a year. It used to take us about 3 hours to do a downtime. And 5 years ago, that was right in line with the national standard for Epic customers. It's a pretty big customer base. Things changed, and we changed with it. And so we took the best practices learned from other institutions, and we implemented them here. As Dr. Mendez mentioned, we got it down to 45 minutes. This is a big deal. If you're working in the emergency department on a downtime on an overnight, which is when we do them because they're the lowest volume, not having the electronic medical record means you can't put in orders. You can't look at radiology studies as easily. And so I think why I want to share it here is, yes, it was a good change that we made in collaboration with the Epic team, our IT teams, our clinical teams, all of those. But we did it because we looked around the country and we said, what are the best practices here that we should be implementing here? And so this is a good lead-in to Epic Honor Roll.
Right,
So
very good.
Epic Honor Roll is a program where Epic looks around the country and they say, what are the best practices? Who's really been successful? And then they build it into their foundation. And then they put it out to their customers as an honor roll. It's around 88 different metrics that they ask you to hit over the course of a year, but it's all based on what has been successful at other customers. So there's about 385 Epic customers out there. 175 of them have ever achieved honor roll. The 2-time achievers, you can see this list, there's 36 of them. We're in that bucket right now. We've hit honor roll the past 2 years here at New York City Health and Hospitals. We're going to be going for a 3rd this year.
I just have to say, it's so amazing when you consider, when you were here, Mike, and you were here, Kim, the state of Epic when we arrived 6.5 years ago.
Yes.
I mean, we had no actual employees who were Epic. Everything was completely consultant.
That's right.
There was a ridiculous implementation time. It was chaotic. The people were leaving. I mean, I always give, great credit to Kevin, who got us back on the path. And then you and Kim and together have done Mr. Lutz, such great work together, sort of keeping it all going. But it's probably the thing, if you looked at all of H&H and said, what changed the most? It would be this and our capability of billing insurance. I mean, those were the 2 things. And they are, of course, related. Right, because we would never be so successful at billing insurance without Epic. But that I didn't know. You guys are very modest. They never mentioned to me that you had made the honor roll twice.
Yeah.
I mean, that's incredibly impressive.
And I just want to say for EITS, our radiology enterprise initiative would not be possible without the infrastructure that was provided by EITS.
Thank you very much. Yeah, I think a lot of this comes down to, a lot of our success has come down to, there are external benchmarks, there's external recommendations, but our ability to speak with one voice and truly have a single electronic medical record and not have 10 different versions of it has really allowed us to optimize the system and make it work. So I think that's a team sport, not just EITS, that's MMPA, nursing, everyone. these are just some honor roll attendees. It puts us in really good stead with who are the national leaders in healthcare. You know, when it comes down to electronic medical records, we are hitting the same benchmarks that they are hitting at this juncture.
I think there's only one other public system on that
Parkland.
list.
You are right. It is Parkland. Yeah, you are right. You know, it's a very wide ranging. It's everything from patient experience to IT infrastructure to population health. I'm not going to get into all of the details here, but this is not an overwhelmingly IT focused project. There's an incredible IT component to it, but we can't do anything without our clinical partners, and you're going to see that in one slide. This is the 88 metrics. It gets harder every year, and that's why I included this slide. So just because we hit it the last 2 years does not mean it's easy to hit it again. So you see the high risk, we have a high risk metric in almost every single category that we are not hitting now. So we are hitting on about half these metrics at this juncture. Means the rest of the year we have some work to do if we're going to hit honor roll. This is very similar to what it's looked like the past 2 years, where we have high risks, we make a strategy, and we go out and implement against it, and that's what we're doing right now.
And I just want to just say that each year the metrics change.
Yes.
So it's very dynamic. Just because you meet it once doesn't mean you get to meet it again if they change.
Yeah, they change and get harder. So you'll recognize the period on the right, the pyramid on the right. What we draw from that is our strategic pillars for New York City Health and Hospitals. We then tied into what our IT goals are. So for example, IT infrastructure enhancement is the IT goal that helps support the strategic pillar of financial stability and quality and outcomes. And underneath that is a metric from honor roll. We would not be doing honor roll if we hadn't looked at those metrics and decided that they really make a lot of sense for New York City Health and Hospitals. We're not doing it for the recognition from Epic. We're not doing it because there's some financial component to it that we get reimbursed from Epic for doing this. We're doing it because it makes sense and they're tied to our system priorities. So for this one, it's the enhanced downtime and business continuity access. These are our BCA computers. So if you have a planned or an unplanned downtime, these are the computers that allow you to look at the patient's electronic medical records. So you know what medications they're on, they know what allergies they have. These are incredibly important to patient safety during those events, and those events are going to happen. They have to happen for a part of like system maintenance, and they are going to happen on an unplanned basis also. So, and, you know, we've made a point of tying all of the different components to what we're doing at the enterprise. I was mentioning our clinical champions. You see this slide there. On the left side is the component, so the honor roll component. Then you have who the IT owner is. But on the right side, we call it the business champion. Typically, this is the clinical champion, but this is who we are partnering with to make it happen. Now, for population health, it's the Ambulatory Care Leadership Council and Population Health. For patient experience, it's the MyChart Steering Committee. You know, you go through each one. For the example, Enterprise Data Analytics, it's our data governance and our DNA colleagues. We have partnered with each of them and gotten their buy-in that these metrics are important to them and these changes are important to them. So we put a lot of work to make this a overall thing that's very important to New York City Health and Hospitals. What does success look like? I'll only hit on a few of these. Provider ease of use. It's a category in honor roll. What we're going to do is we're going to work on personalization of our providers' workspaces. So what this means is, like, I'm an emergency medicine doc. If I have a certain procedure I do all the time, I want to be able to very quickly write that. And, you know, if I typically use a certain size suture, I want that to be pre-populated in my form. Great, I still have to write it and go through and do it, but it makes my life so much easier. It makes it quicker and it makes it more accurate. So what we are doing here is we have personalization fairs at all of our sites. We're sending about, depending on the size of the facility, 15 to 20 trainers are going to go on site. And this has already happened for the majority of our institutions, actually. Go on site and they train people that they can just stop. They can either schedule an appointment or drop by. That's in person. We also have virtual training. We've had virtual training available for a very long time. I got to tell you, the uptake on virtual training is not that high, and the uptake when we go and have a personalization fair has been much higher. So that's a lesson we actually learned from a class survey that we did, that this was a provider want. So we've gone ahead and implemented that. Moving over to patient experience in the next category. Our patients want to be able to schedule online. We want them to be able to schedule on. Our call center has made incredible improvements. It is a great call center. our patients, even despite that, are still demanding to be able to schedule online. If you want to schedule an appointment with your primary care doctor, why can't you go online and schedule it? Why can't you cancel it and reschedule it? That's where we've moved, and that's what we're going to be doing as part of this program. And then finally, I'll mention about data and analytics. On this one, we have so much data now, and it's great, and it really is quite wonderful. But there's so much that's sometimes hard to move through. So what we're doing is we're taking the top 100 reports and dashboards throughout our system, and we're going through and vetting all the metrics to mean they all are talking about the same thing, and we're stamping them as approved. So when you go into our electronic medical record and you're looking for a dashboard, you know whether that's been vetted and when it was vetted and by who. And so I think this is really important for both data integrity and moving us along. I want to be respectful of time. This is just a timeline. We're going to finish up this program in January of this year. And as I mentioned, there is a financial component to it that we get reimbursed by Epic for having hit this. We've gotten a significant amount of money the past 2 years for doing this, which definitely helps. But as I said, this is not the reason we're doing it. This is a nice addition to it. And I'll stop there.
Excellent, thank you, Mike.
Any else? Questions, comments?
I wanted to mention, because she's very modest, that Kim also, besides being the head of IT for the largest municipal system, went back to her clinical practice, seeing patients as a nurse practitioner in our employee health program.
And using the Epic and
And
finding
using
out
Epic
how
and
it works.
Dog food, as Kevin would say.
Yes,
Yeah.
exactly.
Yeah, for 2 years, thank you. And,
That's
it's been
fabulous.
great.
Just a question about, again, it would be spectacular if patients can make their appointments and so on. Sometimes the difficulty is you want to make it as seamless and easy as possible, but if it's so easy, sometimes it's very easy for people to take slots and then the no-shows and so on.
Yep.
And their ability. So sometimes you have to balance a little bit. I'm just wondering, is it sort of built in your concept when you're able to do that, to be able to constantly be reminding and getting some verifications and checking that they're real and all the rest, so that we know that we're getting accurate.
100%. It was actually a concern we had when we were looking at doing this. We learned a couple of things. One, when patients are allowed to make their own appointment, the national literature is very clear that they have a lower no-show rate than when they don't have this capability, and they also cancel and they reschedule better. But even with all of that, your access issue is still, that you raise is still important. We've implemented Hello World, and Epic has a pretty funny name for all of the different things. What this is an SMS or text message portal that allows us in a far more robust manner than we have ever been able to do before to send people a reminder point before their visit and say, hey, you have a visit today. Do you want to keep it? And if you don't want to keep it, we let you reschedule for a new time. It's that kind of thing that's going to drive down our no-show rate. We went live in May of this year with that.
And most
super.
private systems have it. I don't.
It's
from my
mixed. It's
friends-
mixed. Some private systems even use like ZocDoc, and they
Yep.
Yeah,
kind of
yeah.
coordinate. So, and it's interesting because your point is a good one, which is that when you tell a patient this is your appointment 6 months from now or whatever, it's 6 months from now, who knows? When you actually go to the trouble of making an appointment, it makes sense. And yet again, as I said, if it's too easy, and if we don't have verification on there,
It's not for
it
all.
gets a little.
We're not doing it for all specialties in all situations, given some of the access concerns.
So I would say the answer to your question is no for the most part. I don't
That's
think
my
that's
impression.
a
My friends
common
in
thing.
private sector always talk about, trying to call centers and not getting anyone to respond.
So in
Yeah, I
my,
think that's
my
still
chart
true.
has the capability of reminding you in my
Yes.
chart.
And it
Okay.
does.
Often.
Often. I think the other feature that I really like is that if you get an appointment but you would like to be seen earlier, you can go ahead and put yourself on the waiting list.
Yeah, it's
And
great.
because I use our system, it says, yes, I have something. Can you come tomorrow at 2? And so that way, if someone is not showing up or they've canceled, those empty spots are
I think it's
backfilled.
magnificent. I think it's really, and again, it
It's a
sounds
good
like
feature.
we're probably, I think, ahead of some of the private systems. One other quick question is just related to, again, as you're trying to hone in on making it easier for individuals and different specialties to have sort of preset things in their systems so they
Yeah.
can, whether it's medications or whatever. Does it actually get to the point of being provider specific, or is it more specialty specific? Or
Yeah.
how do you kind of get around that?
The personalization metric I talked about there is provider specific. Now, we don't allow our providers to personalize everything, but there's been a lot of research done on what works to allow physicians to tailor themselves and what doesn't, right? So our medication database that we have available, you don't get to tailor that, but within that, you can curate which the ones you typically use. So it's kind of like constrained choice is what we've implemented here to allow it to be better.
Super.
But like I have my diabetes labs,
Right.
because I always order the same thing
Yeah,
for somebody
very
who has
helpful.
diabetes. So I used to have to order them individually, and now I
Justify
type
each one.
diabetes panel, DIAB, and automatically the labs that I would choose to order
Yeah.
then populate, and so I just accept. So, and I'm not a very sophisticated user. I think there are people who are able to personalize large swaths of their care.
And one just parenthetical thing, you can comment or not, just sometimes in reviewing some charts and so on, one of the difficulties is it's magnificent to be able to look at your last note and just duplicate it, but it also tends to sometimes make us a little lazy. And I'm just curious, not expounding on it too much, I think just a real issue sometimes, but any thoughts about that?
We track it closely.
Yeah.
I can tell you, we are right at the national average for parts of notes. Turning up again in other notes is how I will put it. We are right at the national average for that. It's a ECRI, I believe, said one of the electronic medical record regulatory bodies, the wrong word, but advisory groups, said that copy and paste overall, just generically, is something to be managed, not eliminated.
Right.
And
You
that's-
can eliminate the fact that certain things are just constant and
Yeah.
you want to make sure they're there, but on the other hand, sometimes, I hate to say, this goes all across, all providers, not just
Yeah.
the docs, nursing and so on, it just becomes a question like, is it just, too easy? And so I think it's good the thought process is there and we're at least kind of looking at these things and
Michael,
tracking.
why do people do cut and paste? Period. I have to say, if it's already in the note, I
That's
sort of think. I mean, I don't cut and paste. I'm
Yeah.
suspicious of cut and paste. But part of my argument would be, why would I cut? Because it's already there. I'm not. It's not. If you want to see the information, it's there. Why would I take the time even to? I mean, I can sort of see if you're an ED provider, perhaps, right? You're the first, right? And it's sort of a different setting, and you want your ED, but I see in many primary care notes and other specialty notes, people copying their previous note. And again, I'm thinking, but it's already there. Why are you copying it?
I agree with you. Like my rationale, like why I think it's occurring, is just the history of medicine. We are used to. I think a lot of times our residents have been trained that when their attending looks at the note, they want everything that could ever possibly be relevant to be there. That's old CT scans, old lab results, and yes, that's everywhere else in the chart. So no, I don't think it needs to be that. When you look at notes in the United States compared to notes in Europe, they're like 3 times as long. Like it is distinctly different. So I think it's cultural and not so much need. And what I will say just about the copy and paste, we've done our best to do away with copy and paste because that I think is dangerous. Epic has a feature called Copy Forward, which we recently enabled, which updates things. So if I have a patient with congestive heart failure, hypertension, and diabetes, what I will do is if you copy and paste, it's going to say that forever. But if all of a sudden they also have another diagnosis and you add that on the list, it will repopulate and will add it. It will add in the new vital signs, not the old vital signs. So there's ways of making copying safer to better manage it, but we're not going to eliminate it. And I do think working on note length, lots of institutions have worked on this with minimal success because I think we are running into a cultural issue within medicine and what's the expectation of attendings. I don't have a good answer for it. It's
Well,
not needed billing.
The general answer would be, if it's a cultural thing, then you have to handle it culturally. Right. You can. Culture is hard to change, but you can change it. But you have to. I was just thinking. It's just fascinating listening to you talk about it. I've never really thought about it as an expectation. I find it not only do I not find it superfluous, but I actually find it harder when I'm like looking through someone else's notes to find what changed, right? Like if I'm trying to figure out
Yep.
why someone stopped the medication or what somebody did, then I have to look at the previous notes. That's fine. That's how you do that. But the previous notes are so gunked up with this repetitive material that it's harder for me to find what really was new. So I actually see it as a fairly negative thing, and I'm wondering, should we be thinking about what are the right sort of, I mean, if people are doing it because they think this is the expectation, maybe they'd be very relieved if we said, no, this wasn't the expectation.
The problem is sometimes with reimbursement, they're looking at the notes and looking to see different.
Well, I wondered if it's
and
that people,
that's a problem
do
too.
people
if
feel that a
a
longer,
brief note,
but
yeah.
surely you're not getting paid based on
Yeah.
CT scans that
You
were done
should-
before.
I agree, it's not
No.
it might be for a perception of billing, it is not actually helping our billing, the note length. If
I
it's
don't think it-
elsewhere in the chart, we're
Right,
fine.
because you're only supposed to get paid for what you do. You shouldn't be getting
exactly.
paid for stuff someone else did
But I
at
think
some
part of the
point.
culture is to make sure that's clear. The
Yep.
statement you just made and how that, listen, that isn't helping us, and it's not helping you medical legally or any other way, and it's not helping the person who wants to look at your note and see what changed. So I think you said it right. It's an education and part of the cultural piece. I'm going to move on because we have a really great and important Metro Plus report. So let's hear from
Morning.
Dr. Schwartz. Thanks.
Okay, so, sorry. Okay. I'm gonna move to see the screen better. So I'll provide a quick update on the state budget that have direct impact on the health insurance industry. So I'm going to start with the quality pool funding, which obviously is always critical for us, as the majority of the funding actually goes to providers and supports the infrastructure on the provider side to comply and improve the quality measures. And so for the umpteenth time, unfortunately, the quality pool fund was cut, and actually very, very significantly. It's about half of what it was originally. Again, the impact is actually more significant on the provider side because those are the funds that are flowing down to the providers. In addition, there was also across the board plan rate reduction of about 1%, significant impact on the bottom line for Medicaid, and especially for plans who are in the risk arrangement with providers, such as us, of course. Significant impact more on the provider side than on the plan side, but both parties are impacted. And then the new MCO tax, this is really positioned to pull in some of the federal funds into New York State that would apply to Medicaid, CHIP, Essential Plan, and QHP, as well as commercial coverage. Other states are using the MCO tax. It is also used as a stabilization fund, then to reroute funds into the quality pool. So if in fact the MCO tax will be approved, it requires CMS approval. There are multiple steps until it will come to fruition. But if it does come into fruition, it's important, and this is something that we are supporting, to make sure that it will fund the stabilization fund that will allow for.
Been approved in some of the other states that have tried this.
It has been,
CMS
yes.
approved.
New York is now the first,
Okay.
but many steps ahead as expected. In addition, there is also we talked about this, the Medicaid coverage for full dental benefits, where we're talking about the duals plans. Again, we covered this. I'm not going to talk about this again. The fiscal intermediary. This is a huge shift in the industry. So right now, there are approximately 600 fiscal intermediaries in New York State. Those fiscal intermediaries actually are kind of the operational financial arm of CDPAS, so Consumer Directed Personal Services. So the state has been looking for quite a while for a way to cut on the significant expenses in the personal care and long-term care. In fact, they quoted a 1,200% increase in spend on long-term care. And so this is a first step that the state is taking to curtail some of the spend, going from 600 to 1 with some subcontractors. In no likelihood, there also will be dictating essentially the payment that will be going to the agencies. Right now, there is variability between different plans. With this shift, we will be seeing that there's going to be only one rate that will be funded by the state. In this situation, the plans essentially will become a pass-through. So they will be passing the funds from the state to this selected financial intermediary. Nevertheless, although the plans are essentially just a pass-through, plans will be on the hook to administer what's called electronic visit verification. That's to prevent fraud and abuse that we know exists in some cases. And it's a curious kind of a setup, right? The plan is just essentially going to become a pass-through. Nevertheless, the plan is on the hook for fines if the EVV is not implemented and there is any kind of sign of fraud and abuse. This is a really good development, continuous Medicaid and CHIP eligibility for children 0 to 6. Currently, parents of children 0 to 6 have to recertify every year. So if the financial situation of the family remains the same, they do not need to recertify. And we know from our current experience that we're losing approximately 15 to 20% every month of membership because of lack of successful recertification.
Is it self-reported, by the way, as far as the maintenance of the same financial situation, or is it?
It is, although the state does have access to IRS, and so if you suddenly are employed, then you have the state will be able to see that. So this is a very welcomed advance here. On the essential plan, I won't go into a lot of details, but essentially the long-term support services for AP. Some of them are available now, and some of them, depending on the FPL, will potentially become available January of 2026. And then authorizations for new qualified health plan subsidies. So what happened recently as of April, that the EP eligibility increased from 200% to 250. What this means is that a subset of the population that was sitting in QHP now became eligible for essentially free health insurance. The problem is that the remaining individuals in QHP and the plans are now expected to have higher expenses with the shift. So DFS and the state saw this coming, and so they're trying to essentially compensate for it. There are also additional eliminations of out-of-pocket for this population, specifically related to type 2 diabetes treatment. So if we're offering them more kind of allowances not to pay out of pocket, what's going to happen to the premiums, right? So there's a real concern with the premiums. So there is an attempt here to expand the subsidies. So far, we have seen what the plans have submitted to DFS, not what DFS approved, only what was submitted. And on average for New York State, there's going to be an increase of 16% in premiums from 24 to 25 for QHP. So the subsidies, in the first place, it's pretty high, and a lot of people are not able to afford it. And so the subsidies are absolutely necessary. And now with this increase, the subsidies are going to be even more critical. I just wanted to do a really quick review of the food programs that Metro Plus Health is offering. We have 3 different food programs that we are offering. We'll not go into detail except for the fact that the medically tailored meals are part of our Medicaid benefit package for eligible individuals. So far, we had approximately 1,500 members who received the medically tailored meals, and this is in collaboration with our vendor, God's Love We Deliver. And just wanted to share with the committee the feedback that we've received so far from our members. So 95% of the members who were surveyed expressed satisfaction with the medically tailored meal program, and 94% of the members surveyed felt that the meals assisted them with managing their disease. It has been in place for 2 years now. We're not in a place of measuring the financial impact yet, so I'm showing the satisfaction, but we will be and are looking at the financial impact. I think intuitively we know that it helps and the feedback is positive, but we're planning on running the actual analysis and bringing it back to the committee. You know, just a little note here that the members get a birthday cake on their birthday, and really the meaning of it is, for some members, that's really the only acknowledgement of their birthday. The other program I wanted to quickly review here is the peer-to-peer mentor program for members who live with diabetes. I think you're aware of this program. I'm bringing it back here mostly to show an analysis that was done by an independent entity by UCSF, who look at the data to see whether the program is in fact effective. So just a quick recap. We are connecting members who live with diabetes, those with controlled diabetes, and those with uncontrolled diabetes. And we do multiple matching. It's not just diabetes, it's also language, cultural backgrounds, etc. And the members work with their peer not only on diabetes, but obviously on other impacts, other issues that impact their diabetes, such as social determinants of health. So you see here a list of other challenges that the members are dealing with, to nobody's surprise. And so here's what we have seen, that overall 70% of enrolled members showed improvement in their diabetes control, which is a reduction in their A1C. So in 2023, the average A1C reduction was 1.3%. And since 2020, over 500 members had at least a 2% or greater reduction in A1C. Obviously, there is a correlation between A1C and then morbidity and mortality and the complications from diabetes. Among the almost 1,600 members who were enrolled in 2023, many social determinants of health were identified and addressed. 28% were referred for food insecurity. Luckily, we have multiple programs that actually can provide support for food insecurity. And 7% were referred for housing issues, mostly for homelessness. So this is not just about appropriate diet and medication adherence. It's also everything else that's impacting members' health. Okay. I'm bringing the spring campaign only because I am sure that if you live in New York City, you see our ads everywhere. Um, and what I wanted to show you, I mean, obviously the marketing campaign is really to bring general brand awareness. We increased the campaign when the EP eligibility went from 200% to 250 to capture those additional individuals. Um, and so this is just a reminder what it looks like. Most importantly, here's what we're seeing in terms of kind of initial ROI on the marketing campaign. What we really want to see that people come to our website and then obviously look at the options that are available to them and ultimately enroll. And the numbers are really pretty impressive since we launched the campaign. You see that there was almost a 50% increase in new visitors to the site. Organic search, meaning people actually typing in MetroPlus Health, is up more than 40%. And direct, so this is on the Google search, or just actually typing metroplus.org, again, over 50% increase. And we are seeing a significant increase into our ACD line where we have our sales reps. And then I just end on another positive note here is our really incredible collaboration with Elmhurst, not just around kind of the redesign, but generally speaking. Elmhurst has approximately 24,000 of our members. And so a lot of the enrollment is happening in the hallways of the hospitals. And so it was time since we changed our entire branding, we changed what we look like. It was time to update the space where all of this magic is happening. And what you're seeing here is the before and after. It's really an amazing transformation. Patients feel more welcomed, members feel more welcome. There's designated space, there's more presence. Elmhurst accepted this with open arms. We were happy to do this. We also have done some work at Lincoln, and the plan is, as the hospitals, are interested, that we will continue to do this throughout the system. Thank you.
Great report. Any questions,
Real quick
comments?
question.
Jeff?
Because I know we're out of time. The CGPAP program is where individuals are authorized to provide care themselves, to assist with healthcare needs of elderly residents or disabled residents. Is there any criteria for who can do it? I was just curious about how they're even selected.
Yeah, so essentially the member can select whoever they are comfortable with. So it can be a family member, it can be a friend, it can be a neighbor, it really can be essentially anyone. And the whole point of CDPass was that a lot of people who needed assistance with daily living activity did not feel comfortable with strangers coming and taking care of them, sometimes in a very intimate manner. And so they were refusing care. So there was a very good reason of why this whole concept was generated, but I think where you're going is, it's very, very open in terms of who can provide that assistance, and you are correct.
And the electronic visit verification, how does that work? How does the electronic piece of the visit verification work?
Yeah, I mean, essentially, it's checking in that you are the location that you're supposed to be at.
All or
I'm sorry, I don't know the details.
okay.
The reason it was implemented, again, there were circumstances, and it was not rare, where essentially the services were not provided, and then the fees were paid and split in all kind of ways between the member and the potential caregiver. So that will not occur. That's why the EVV was implemented, but I don't have the details of how specifically it works.
That was it. I was just curious about. I mean, it ballooned. It just hundreds of millions of dollars, and it just seemed to have so little control, like who can do it, how they do it, how you know they're doing it. It's just interesting how a concept that's good, I mean, it had a reasonable foundation, but it can get out of control.
Yeah, the thing is, it's always been in the system that there are caregivers to elderly that were not compensated, and
Right.
so the concept was great. Let's try to make sure they don't have to go and get outside, care. But like you said, it's challenging because it's like, oh, my daughter lives upstairs. This is great. Let's now get paid for it. So there's, and what are your skills? And again, it's just helping bathe and so on. But some of those things do require some real training and skills. So it does, have its issues, I guess. And then again, it's our responsibility to make sure that we verify and so on. So yeah, I'm familiar with this. Is basically that phone calls, or sometimes they have to call in, they've arrived and whatever, and then checking with the member to do they come and all that. But again, particularly if you have those issues where the member and the provider are, working together, it becomes an issue. So it's got its, as everything else, there's the great good that comes out of great concepts, and then there's always the abuses, and our job is to try to minimize them. And of course, it's our responsibility to make sure it's not. So, all right, excellent. Any other questions, comments? Super. Any old or new business? If none, meeting's adjourned. I thank you all.
Thank
Great
you.
reports.
Well done.
This meeting is no longer being recorded.